We'll start our session on infectious disease and cancer care. I welcome you all. I'm Azra Parveen, one of the infectious disease consultant here at Shaukat Khanum Hospital, Lahore. I will invite Dr. Ijaz Ahmed, who is the chair for this session. We'll start off with the first talk. This is by Dr. Amir Kazi. Dr. Amir Kazi is Diplomat American Board Internal Medicine and Infectious Diseases. He's also done fellowship in transplant infectious diseases. He's currently working in this hospital, Karachi, and he will talk about management of mucormycosis. Dr. Amir Kazi, please.
Thank you, Dr. Azra, for the invite and for your generous introduction. So today I'll be talking about the presentation and management of mucor in cancer and stem cell transplant patients. These will be the objectives for today. I will focus on some of the mucor data that has come out from Pakistan. We'll review the international guidelines and how to treat these complex patients, and covering things like salvage therapy, combination therapy, breakthrough. And we'll also talk about my own Indus mucor experience and how we can actually apply these guidelines and manage things in Pakistan with our limitations. So when we talk about the epidemiology of mucor, it is good to see Pakistan light up on a map since we're now publishing more and more data. 10% of invasive mold infections in stem cell transplant patients are due to mucor. Various prevalence and incidence data have been reported across the world. From transplant centers, 0.4 to 5% incidence has been reported. And across all these studies, they note that there is an annual incidence which is rising. And that's why it's become more of an issue. And we're talking about this today. If you look at the last 50 years, we're seeing more mucor in diabetes, in solid organ transplant, in stem cell transplant, and in malignancy. And so it has become a major issue of late. When we look at some of the data from stem cell population, this was from the TransNet study. This was published in 2012. So old data, but we can see that in this study, their 12-month cumulative incidence was around 0.29%. And so they were looking at over 15,000 transplants, and they found 44 cases of mucor. And they found that the most of these were in the allo unrelated population, and the least were in the autologous. And they also found that these cases would either present early or quite late post-transplant. So the risk groups for mucor, diabetes is of course a big one that has been kind of a global risk factor. And the challenge in Pakistan is that since we're leading in diabetes, we have been seeing more and more of mucor in our diabetic population. We are also now dealing with more malignancy and transplants in Pakistan. Within malignancy, it's more commonly found in hematologic malignancy over solid organ, and more in stem cell over solid organ transplant. Trauma, surgery, and burns are also risk groups. And then there are various other risk groups. So for example, COVID, use of steroids, lung disease, also with use of steroids, HIV, which we're seeing a rising increase in Pakistan, along with a lot of malnutrition, CKD, CLD. So a lot of these risk factors do apply to us. In the malignancy and transplant population in particular, prolonged neutropenia with cytotoxic chemo, prolonged high-dose steroids, grade 3, 4 GVHD, prior CMV infection, and VORI prophylaxis have all been associated with mucormycosis. When we look at mucor in malignancy in particular, the most common manifestation is going to be pulmonary mucor. This is different from, let's say, diabetic mucor, where we're seeing more rhinocerebral. But in malignancy in particular, more than half the cases involve pulmonary mucor with cough, prolonged fever, chest pain, hemoptysis, dyspnea, or even asymptomatic infection. Often the way it's discovered is prolonged fever is the most common symptom, and the evaluation of prolonged fever in a malignant patient leads to finding certain types of opacities on the CT chest, and that kind of leads down the road to mucor. But in addition to pulmonary manifestations, about 25% would be sinoorbital and rhinocerebral disease, cutaneous disease, and then disseminated disease. And the presentation for mucor and stem cell is also similar, more than 50% being pulmonary, and then sino-orbital and rhinocerebral is about 25%, and then again cutaneous, gastrointestinal, and disseminated. The mortality in stem cell is quite high, can range between 30% to 90%. Median survival has been reported as being less than 2 months sometimes. So patients can be quite sick from this. And so we look at certain clinical cases. These are actual cases that I've encountered, some in Pakistan, a few abroad. And we'll just work through some of these cases of how the presentation can manifest. So this is a patient with ALL that undergoes stem cell transplant with myeloablative conditioning, has delayed engraftment with prolonged neutropenia, is on fluke prophylaxis specifically because they had a bad intolerance to posaconazole with a lot of vomiting. And we can see that 4 weeks post-transplant, his fever evaluation shows a right mid-lung nodular mass, and right there. And then BAL cultures were negative. So an early BAL was done. The patient has progressive shortness of breath and cough. And over time, his CT findings progressed to a cavitary and consolidative masses over there. And lung biopsy is opted for eventually, and that reveals aseptate mold, and it actually grows rhizopus. So the reason for sharing this case is that this is actually probably a common scenario where we'll do a BAL and we won't be able to come to a conclusive diagnosis in this sick patient who's taking some form of prophylaxis. And so this kind of highlights the importance of doing a lung biopsy and trying to get tissue wherever possible, wherever platelets and neutrophils allow. It's important to do so. This is a case of disseminated mucor in a relapsed refractory AML patient who had received cytotoxic chemo, steroids, had prolonged neutropenia, and thereafter developed necrotic ulcers, followed by purpuric nodules on the skin. A CT scan done for staging and identifying source of fever revealed a subcapsular hypodense liver mass right there. So skin lesions in this population are always an exciting and long differential, and therefore they require, once again, biopsy wherever feasible. And so this patient's skin biopsy showed aseptate angioinvasive mold, and this is what the appearance. So these are representative images, and we can see how the typical findings will be these broad aseptate hyphae. Sometimes they can be pauciseptate, but mostly aseptate, and they're kind of ribbon-like in nature. Some cases of sino-orbital mucor that I'll share with you. So this was a laborer from Balochistan who had been taking Hakimi medicines, and we were convinced that was probably laced with some steroids in there. He presented with chronic oral and facial pain and swelling with this necrotic fungating palatal lesion, as we can see. He had an ENT biopsy, and this revealed aseptate hyphae. He received a course of amphotericin and got better. The challenge in this patient was that he was coming from very far. So we had to discharge him and actually utilize 3 times a week amphotericin through the daycare facility because he was, even though he had moved close to Karachi, he was still quite far from our center. This is another case of sino-orbital mucor in a laborer from KPK who had chronic oral and facial pain with this foul-smelling lesion with this on his palate. So he underwent an ENT biopsy. It revealed aseptate hyphae. He had to undergo extensive resection and palatal reconstruction. I share this case because this patient was treated with ampho and did quite well as far as his disease goes. We were able to kind of cure him from from a mucor perspective, but he was left with these gaping holes in his palate. And so this is a practical complication that we'll see from a lot of resection that has to be done for these patients. And once once their disease is controlled, they have to undergo palatal reconstruction, which means finding the right maxillofacial surgeon in Pakistan with the right equipment. Usually there's just a few providers in the country. The equipment is very expensive. There are import issues. So you can imagine that we actually had to treat this patient for a long period of time until we could actually ensure that he underwent reconstructive surgery, which was not available at our center, and the patient had to pay for that out of pocket. So even for our treated patients, we can run into such issues. This was a patient, another patient with sino-orbital mucor who had uncontrolled diabetes, numbness of her swelling, upper gums, which had progressed, and she underwent a FES biopsy that revealed broad aseptate hyphae. This initial care she actually received outside of our center, but it was at a major tertiary care center in Karachi. And initially, she was managed with Vanc, Miro, and amphotericin, developed AKI, and then was discharged 5 days later on fluconazole. I highlight this case because it it was a reminder to us about how there can be a big knowledge gap even in 2023, 2024 about how to manage these patients, whether it was an affordability issue or not, whether they even had infectious disease support or not is, I think, a secondary issue. It's really quite negligent to be discharging a patient on fluke that has no mucor activity. The same patient presented to us later with disease progression that was seen on her FES and on her CT as well. And you can appreciate that her sinuses are quite diseased and it's eroded through bone and involved multiple sinuses. She had to undergo extensive debridement and then eventually responded to liposomal ampho. She had AKIs with deoxycholate. And eventually, her disease did get better. And this was our first experience with isavuconazole. So after 2 months of ampho, we actually were able to arrange isavuconazole through my center free of cost to the patient. And then she overall responded quite well. I share this imaging because this is actually her disease doing quite well, but we can see a lot of gray opacities on the CT still. And the challenge is that even with a well-debrided patient who might have stable disease or in remission, we will see a lot of CT findings that can be mucosal edema or granulation. And so the CT reports can be quite challenging and they have to be taken in context of the endoscopic findings. COVID-associated mucor, this was another case, sick patient, renal transplant, CRS, ARDS, prolonged intubation, got lots of antimicrobials, and then had recurrent and persistent fevers, worsening hypoxemia, worsening chest X-ray, and bile and tracheal cultures grow rhizopus. So this is a newer entity, COVID-associated mucormycosis, CAM, and we've seen it through our COVID waves. I'll talk about some of the data from Pakistan. So it's nice that we're now seeing a lot of data. In fact, Dr. Nausheen, who's our next speaker, I'm actually referring to her data and her colleagues' data, Dr. Kausar from AKU. So it's nice to see that we're now finding more of our own data. And so the mucor species in Pakistan that have been isolated are Rhizopus species, mucor, Lichthyma, Syncephalistrum, Rhizomucor, and Cunningham ella. And by and large, this is quite similar to the international data as well. So Rhizopus species is most common. This is Dr. Kausar Jabeen's AQ data that she's been very kind to share. This is her unpublished data from 2023-24 for over 25 patients, and she was looking at mucor sensitivity at AKU, and it's the data was overall in some ways alarming and in some ways reassuring. So green is good, that's sensitive, that's a wild type. Red is resistance, and that's non-wild type. So in Dr. Koster's data, they had 100% amphos sensitivity, and for isavuconazole, they had 73% sensitivity. And this is, as a reminder, around the time that Isavu has just been launched in Pakistan. So it's still a very new drug. And for POSA, they found much lesser sensitivity at 40%, which is very alarming. And I'm not sure about the background of those patients. Maybe they were posaconazole experienced patients, but this data is helpful that at least AMPHO that we can rely on. And it's concerning that our azoles are quite resistant. I'll talk about the global guidelines for Mucor. And let me see if I can zoom in here. All right. So this is kind of my favorite guideline because with Mucor in the past, there was a lot of different approaches to treating Mucor across the world. And so Dr. Corneli et al. And the European mycosis group developed this guideline. So by and large, we have kind of the four big areas. We have neutropenic and transplant patients, we have diabetic patients, trauma, and then abdominal Mucor in Asian patients. We want to do dedicated imaging across the board. And in neutropenic and stem cell transplant patients, we definitely want to prioritize chest imaging. But then we also, in these immunocompromised patients, we want to stage them for other sites of disease. So doing kind of like a pan CT will be important, followed by sampling with biopsy. We want to be careful with our sampling and processing because when we grind samples, they can become non-viable, and that can affect our culture growth. And then sending all tissue in formalin for histopath, but also in saline for culture is important. And these are still the main ways of diagnosing it. Although Mucor grows well, but again, if we run into non-viability issues, that can affect our culture positivity, and we can have false negatives around 50% in Mucor culture. Looking forward, we'll be seeing more of, I think, PCR and MALDI-TOF in the future. But the issue even now in the West is with how to validate PCR results and MALDI-TOF. CT findings in Pakistan from our own studies show consolidation, nodules, effusion, cavities, and pneumothorax. And as kind of the findings that we see, reverse halo we talk about a lot, but we see it less commonly. Most commonly, it's consolidation and nodules. So consolidates with surrounding ground glass over here, nodular opacities like this. And that's a reverse halo sign with a solid rim and some internal ground glass. So we're going to move on to treatment. I'm running short on time, but I'll try to run through this. So for treatment-wise, the most important thing is really doing surgical debridement as an emergency. So early diagnosis, early surgery, and early antifungal therapy is all associated with improved survival. So we want a surgical debridement for disease control, for diagnosis, but we also want clean margins. It's a very important endpoint with surgery, and it may require repeat debridement. For pulmonary Mucor, that's more of a challenge, but even in stem cell transplant patients, there is data showing that patients who eventually underwent pulmonary resection had better outcomes. When we talk about antifungal therapy, the mainstay that all the guidelines recommend is liposomal ampho at between 5 to 10 mg per kg. If there's CNS involvement and perhaps in transplant, we can use the higher dose of 10 mg per kg. If there's pre-existing renal disease, we can rely on ICAV or POSA. Generally, the guidelines do prefer AMPHO as initial therapy and not ICAV and POSA as initial. And the POSA oral suspension has absorption issues that is discouraged. Lower doses of AMPHO are not. And the guidelines, because they have access to liposomal, they want to avoid amphotericin deoxycholate because the data is better for liposomal as well. Once we've started IV AMPHO, where we're really looking for is what is our response. So if patients respond well, we can continue with AMPHO or switch to azoles. If there's disease progression, the global guideline recommends bumping up the dose of AMPHO if not done so already, or switching to azole therapy. And if there's toxicities, again, switching to azole therapy. In salvage cases that we'll talk about, that's where the guidelines have talked about combination therapy of AMPHO and POSA for salvage cases. Duration of treatment has to be individualized. It is not well defined. The idea is we want to treat until clinical and radiographic resolution, and we have some reversal or control of immunosuppression. And the average duration would be 3 to 6 months is what's reported in the literature for disease stability or cure. But of course, we may need longer durations for sicker patients. And therapeutic drug monitoring for POSA, keeping troughs above 1, is important to prevent failure. So I'll talk about combination therapy. And generally, initial therapy with two agents is not supported by any of the guidelines, global, ESIL, Australian, or German. And the reason for that is a lot of the combination therapy data has been case reports and case series. And so it's been very heterogeneous and even biased data. These two studies I've highlighted actually had a much better quality retrospective data, and they found that there was no benefit of initial combination therapy. This is Dr. Contonianis' study from the MD Anderson, which is a big stem cell transplant center. And this was, again, looking at initial therapy. They had a lot of sick patients with leukemia, active malignancy, stem cell, and GVHD. And they compared mono versus combination with various combinations. And they found there was no mortality difference at 6 weeks with propensity score adjusted survival curves. Similarly, they divided into low risk and high risk groups. And even in the high risk group, which were quite sick, ICU admitted patients, disseminated, higher Apache scores, they again found no difference in mortality between monotherapy and combination therapy as initial therapy. I want to share this study because it's very important to interpret data with caution because there can be a lot of bias. This is a study from a review, retrospective multi-center review from 10 transplant centers published in 2020. And as we can see, let me get the pointer out. Okay. So they reported that in the AMPHO plus POSA group, they saw lesser mortality compared to just AMPHO alone. But if you look at their surgical debridement data, that difference in mortality can easily be made up by the difference in surgical approach. Their patients who got a combination therapy also got more surgical debridement and earlier surgical debridement. So this was one of the critiques of the study. And so that's why we have to interpret data with caution. Combination therapy is not a replacement for surgery. There's lots of data talking about surgery improving mortality. This is just from 2023. We can see in the group that had surgery done, they had much lesser mortality, significantly lesser mortality. However, surgery did not impact the outcome of pulmonary or disseminated mucor in this study. For salvage therapy, the global guideline talks about using ISAVE or POSA. The ESIL-6 offers that, or lipid, AMPHO, and POSA, or AMPHO and caspofungin as well. And we'll talk about how to implement that in Pakistan. Adjunct therapies, GCSF is moderately recommended. Diabetic control is very important, and decreasing immunosuppression, in particular steroids, wherever possible. Iron chelators is a big no, and oxygen is a weak recommendation. Prophylaxis, usually for mucor, we're not really targeting primary prophylaxis. There's been no evidence in favor of that. But in virtue of neutropenic and GVHD prophylaxis, they do receive POSA coverage. And secondary prophylaxis is not really recommended. But if there is an upcoming transplant, then one can continue with therapy. Complications are pulmonary and then dissemination and periorbital destruction. I just want to talk about breakthrough invasive infections. So this was a big review just recently published that talked about breakthrough mold infections on POSA prophylaxis and VORI prophylaxis. And VORI, of course, does not cover mucor, so we saw more mucor in that population. And however, the point I bring this up is that we can't cover for all possibilities. And so even on expensive therapies, bugs will break through, and that's going to be a challenge. They found resistance in 1/3 of patients and subtherapeutic levels in 1/3 of patients. So we should try to monitor drug levels wherever possible. This is just some of the data from our unpublished data from Indus. Presentation-wise, we saw a lot of rhino-orbital and sino-orbital disease, a lot of diabetics. We did have patients had to undergo repeat debridements and mostly received AMPHO. This is in the pre-ICVU era. And AKI was seen commonly. This is just 10 patients, just very limited data, but 4 expired from here. This is our algorithm that we've developed at Indus on how to approach mucor management with all the limitations in Pakistan. So we're of course relying on amphodeoxycholate 1 to 1.5 mg per kg daily. We combine that with close coordination with ENT for surgical debridement until clean tissue is seen. We send off the workup. We actually work a lot in our low income setting on controlling risk factors for these patients and managing their mucosal edema. Sometimes patients will have a lot of post-surgical sinus pain and swelling, and that may not be their disease coming back, but it's just a lot of edema. We image them 2 weeks later. If they're doing well, we'll most likely keep them on inpatient ampho if they can stay inpatient. If they're coming from far away or they have to get back to work, then we do thrice weekly outpatient ampho. We hope to publish this data in the future. We've seen good outcomes with this, and where we can afford to arrange ICV or POSA, we will try to do that. If patients their disease progresses, then we will try to repeat debridement, control risk factors, increase ampho dose, and if all else fails, then it's combination therapy at some point. And this is just it. Yes. So just the last one. This is an equal scorecard of reminders of all these points. And I shall end with that. Thank you. Sorry for going over time.
Is Dr. So my next speaker is Dr. Nausheen Nasir. She is consultant infectious diseases at Ahan University Hospital. She's section head infectious diseases, and she's vice chair research and also chair of the antiviral stewardship committee. Dr. Nausheen Nasir.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. First of all, I would like to thank the organizers for inviting me to speak on this occasion and for that kind introduction. So we are going to be switching gears a bit, and we're going to talk about cytomegalovirus, which is one of the herpes viruses. And we want to talk about the impact of cytomegalovirus infection on bone marrow transplant outcomes and some strategies for early detection and management. So just to give you an overview of what we are going to cover, we are going to give an introduction of CMV in BMT and define some of the key definitions, look at the epidemiology pertaining to Pakistan. And then we'll talk about the impact of CMV on bone marrow transplant outcomes, risk factors, clinical manifestations, strategies for early detection, some of the management approaches, and the challenges that we face with this infection. So just to tell you about CMV infection, it's a common viral pathogen which has a very high prevalence in transplant patients. As you can see from this data, the people at the greatest risk are those who have undergone allogeneic hematopoietic stem cell transplant and who are seropositive patients. They are at increased risk because of CMV reactivation due to the immunosuppression that they receive as part of the transplant. And what we know from literature is that CMV reactivation occurs in up to 80% of patients, seropositive patients. Primary infection affects 20 to 30% of CMV seronegative recipients who are transplanted from serum positive donors. And what we know is that it can significantly impact the outcome of the transplant, and it can affect morbidity and mortality. So let's just look closely at some of the definitions. And this is quite new because the new consensus has come out in September 2024. Most of the definitions that they have revised have been from the previous 2017 recommendations with only few changes that they are recommending. What we need to know is the CMV infection is defined as a virus isolation or detection of viral proteins or nucleic acid in any body fluid or tissue specimen. It is important to distinguish between CMV infection and CMV disease, because disease means that there is presence of signs and symptoms of the infection as well. And we'll talk about disease in a while. Primary CMV infection is defined as the first detection of CMV infection in an individual who previously did not have evidence of CMV. And recurrent CMV infection is defined as a new CMV infection in a patient who did have previous evidence of CMV, but for whom the virus was not detected for a 4-week period during active surveillance. Now, recurrent infection may be the reactivation of latent virus, endogenous, or it may be reinfection or acquired infection. So reinfection is defined as detection of a strain that is distinct from the strain that caused the initial infection, whereas reactivation is likely if the two viral strains, current and prior, are found to be indistinguishable. And the way to differentiate between the two is through sequencing the specific regions of the viral genome. Now, very little data is available from Pakistan. The only study that I could find was from 2023 from AFIP, Rawalpindi, and they showed the data for 230 patients who underwent allogeneic hematopoietic stem cell transplant. And their pre-transplant CMV seropositivity was 99% for recipients and 99.5% for the donors. So giving you an idea of Pakistan, which is a highly prevalent, infection in our population. So it is unique in that way. And what they found was that CMV infection occurred in 66% of the patients that underwent transplant. Median time to development was 36 days. And they gave preemptive antiviral therapy with vancomycin and ganciclovir to around 140 patients who had a CMV viral load of 2,000 copies. And the overall survival showed that there was a reduced survival in those in whom there was CMV reactivation, and this was statistically significant. So that brings us to understand why we are discussing CMV today, because there is a major impact on BMT outcomes. Uncontrolled CMV reactivations can lead to life-threatening multi-organ disease. And the higher mortality is in the absence of early detection and treatment. Before effective antivirals, it was attributed to 25 to 30% mortality in patients, in those in whom CMV disease developed. Now, who is at higher risk for death? Well, it's higher in CMV seropositive patients who are undergoing allogeneic hematopoietic stem cell transplant compared to CMV seronegative patients. And it is higher when the allograft is from an unrelated or mismatched donor. And it is also higher if the donor is CMV seronegative. So those are the important things to keep in mind when we are treating patients, because we are in a high endemic area. CMV reactivation is known to increase risk of graft failure, severity of GVHD, although there is conflicting data, but there is some data to support that it does contribute to GVHD. And then it causes excessive hospitalization and healthcare costs as well. Now, in a large study of more than 4,000 patients who underwent hematopoietic stem cell transplant, they found that while there was no increased risk of acute GVHD, there was an increased risk of invasive fungal infections and bacteremias in patients who had CMV viremia. And the reason for this is because CMV itself causes immunosuppression. And so it leads to these complications as well. So the impact, we know, is huge. So what do we need to understand now is that who is at risk and who do we keep an eye out for? So what are the factors which place recipients at highest risk for CMV infection and disease? The first I already mentioned, seropositive recipient. Then the transplant type. It's the highest risk for those who have had an allogenic mismatch, followed by haploidentical and then cord blood transplants. If the conditioning regimen had alemtuzumab, which is an anti-CD52 antibody, ATG, anti-thymocyte globulin, fludarabine, which is used as part of autologous transplants, high-dose steroids. All of these are associated with an increased risk and advanced age. So between days 0 to 29, these patients are at high risk for CMV infection and disease. Then, in addition to these prior risk factors, between days 30 and 100 is the time when we start to see GVHD. And in patients in whom there is a delay of T cell recovery, these are the patients who are at highest risk for CMV infection. And in patients post 100 days of transplant, excessive steroid use, delay of T cell recovery, non-myeloablative conditioning, and CMV reactivation prior to day 100 is associated with increased risk. So presence of any of these factors would place the patient at a higher risk for CMV infection and disease post-transplant. And if you look at the time period for CMV here highlighted in yellow, you see that between day 30 to 100 plus, so around the second year post-transplant, patients, so first year within the transplant, the patient are at the highest risk. Then we talk about the clinical manifestations of CMV disease. So CMV disease is associated with end organ disease. It can involve any organ, but predominantly in patients with who have undergone bone marrow transplant, the site of infections are pneumonia, gastrointestinal disease, retinitis, and rarely encephalitis and hepatitis. So differentiating CMV disease from other infections is essential for accurate diagnosis. There is a term CMV syndrome, and that is used in solid organ transplant recipients. It is not applicable to hematopoietic transplant recipients. So over here, I'll just give you a brief idea of how we are defining the disease entities. And so when we look at pneumonia, there is proven CMV disease and probable CMV disease. Proven CMV disease is when there is a presence of clinical signs and symptoms followed by a documented infection in the lung tissue, either by virus isolation, rapid culture, histopathology, immunohistochemistry, or hybridization techniques. The infection is probable if on BAL you find CMV DNA of more than 10 to the power 3 high power field. So the definitions right now previously did not include this BAL criteria because it's still non-specific, but the absence of CMV in BAL can exclude the possibility of disease. So if there is then viremia there, viral load there, then you need to consider the possibility of CMV pneumonitis. And this is what basically this slide is showing, is that there are several different disease entities. All the rest of them, and I'll talk about GI in a bit, but are rare, but all of the criterias require that there is detection in the presence of signs and symptoms. There is detection of a virus in the tissue. And that is the latest in terms of the consensus statement from the different organizations. Now, talking about CMV in gastrointestinal disease, it can involve any part of the GI tract. And for allogeneic hematopoietic stem cell transplantation, for proven disease, you have to have the symptoms plus endoscopic findings consistent with infection. So there could be ulcers, there can be erosions, and plus you have to have documented CMV in the tissue biopsy. You call it probable if you have the symptoms and the tissue biopsy from any detected from any the virus detected from any method other than the PCR, but without the macroscopic mucosal lesions, and possible if you have the signs and symptoms and you have tissue diagnosis PCR based. And for autologous, it's a similar criteria, it's the same criteria. So how do they present? Well, between days 0 to 29, the disease is rare, but the infection can be throughout, post-transplantation. Between days 30 to 100, patients mostly present with pneumonia. It is the most common end organ disease, but now the incidence has been lowered because of the preemptive and the prophylactic therapy, which we'll talk about. But it's still the incidence is between 1 to 9%. And after days 100, then patient can present with pneumonia, GI disease, CNS disease, and retinitis. For pneumonia, on CT, you see the ground glass opacification. There can be consolidations, and usually it is a bilateral presentation. For retinitis, there are peripheral retinal hemorrhages and ischemic changes. And in GI, you can see mucosal ulcers. And in the biopsy, you see the typical owl's eye appearance of the intranuclear inclusion bodies. So what are the risk factors for progression from CMV viremia to disease? So patients who have had a high viral load, especially more than 20,000 copies per ml. Then leukopenic patients are at the time of initial detection, leukopenia at day 100 post-transplant, refractory CMV by day 100, so somebody who is not having a reduction in their viral load, and possible associations are with the GVHD, with high-dose steroids, with T-cell depleting therapies, and delayed T-cell reconstitution. So how do we define refractory and resistant CMV? Refractory CMV is defined as CMV viremia that increases the peak viral load or persists after at least 2 weeks of appropriate antiviral therapy. And resistant CMV is, in addition to this, there is presence of viral mutations which are reducing the drug susceptibility. So you do genotyping to determine whether it's resistant CMV. What are the available to us? We have the PCR-based monitoring and the antigenemia assays, but specific viral loads for preemptive therapy are not standardized. So each center is required to have their own threshold. The emphasis is on individualized assessment and monitoring. So the key thing to learn about CMV is that you have to understand the viral load dynamics in the patient, and that will guide your initiation of antiviral treatment. So guidelines usually recommend that you monitor them weekly with a PCR or with a viral load, quantitative PCR, first 100 days post-transplant, especially in patient with persistent T-cell immunodeficiencies. So we have the quantitative PCR, which most people are familiar with, which measures the viral load in the blood or the plasma samples. And while it is good for detection of viral replication, it does not tell you about, it does not diagnose CMV disease. Then viral culture, it's a method of involving the isolating the virus from the blood or the body fluid, but we know that it is time consuming and is not available in most parts of the parts of the world. In terms of antigen detection, we have the PP65 antigen tests available to us. This can provide rapid results and is useful for diagnosing active infection. Serological tests are only of value prior, so pre-transplant workup when you are determining the serostatus of the patient. And tissue biopsy is required for establishing the CMV disease from whatever the site of infection is. Strategies of early detection, we mentioned the guidelines recommend routine monitoring PCR every 1 to 2 weeks post-transplant for high-risk patients. Different institutes have established their own threshold depending on the assay that they are using. Generally, viral load of greater than 2 to 3 log to the power 10 often prompts intervention. Serological testing for guiding those who are at increased risk for guiding, prevention strategies in them. And then immunologic monitoring, which can help predict the risk of the infection and guide the management decisions. These are relatively newer tests and not available in most parts of the world. So let's talk about the management strategies. So there's prophylaxis and preemptive therapy. Prophylaxis is giving antivirals to all the patients at risk prior to the onset of CMV infection. Preemptive therapy is routine monitoring of the infection. So you monitor weekly, you check the viral load, and you treat depending upon the detection of asymptomatic CMV infection based on a pre-decided threshold. So there are different pros and cons to each. For prophylaxis, it can prevent the direct and the indirect effects. So the direct effect of the virus is because of its own the damage that it causes to the and causes end organ disease, and the indirect effect is by causing immunosuppression and causing secondary bacterial and fungal infections. Viral load monitoring is not required. So if all the patients are on prophylaxis, then you don't need to regularly monitor their viral loads. But and it also prevents CMV disease, which may occur without detectable CMV DNA, and we know those can happen despite so checking the viral loads periodically. But there are certain cons to it. The first being that there is a potential for overtreatment and the added cost. and unnecessary exposure to drug toxicity. We know that ganciclovir can cause myelosuppression, foscarnet can cause renal toxicity. And then it also delays CMV specific immune reconstitution, which is essential for controlling the disease. So those are some of the disadvantages of prophylaxis. For preemptive therapy, it targets patients who are at the highest risk. It minimizes overtreatment and toxicity, and it actually may improve the CMV specific immune reconstitution. Whereas it has a potential to miss the disease, which is not preceded by anemia or antigenemia, and it relies heavily on the availability of CMV testing. And there is a concern for drug resistance because there is a possibility of high viral replication and suboptimal drug exposure to the virus. The different antivirals that are available to us, the more prominent ones are ganciclovir and valganciclovir, and these are the first-line agents. The valganciclovir is a prodrug of ganciclovir and has better bioavailability. Foscarnet is an antiviral which is used in cases of ganciclovir resistance because it requires careful monitoring. It's an alternative for the patients. Letermovir is one of the newer agents which is shown to reduce the incidence of CMV disease, and it is being favored for prophylaxis in CMV seropositive transplant recipients. Maribavir is one of the new investigational drugs which is being evaluated for management of refractory cases. And CMV-specific immunoglobulins, or rather IVIG as well, has been used in some of the cases, especially where the disease is very severe, particularly severe pneumonitis due to CMV. So we've already discussed the strategies. The important thing to remember here is the duration, which we haven't talked about. Duration is until at least the indicator test that you started the treatment based on that test is negative, and the patient has had a minimum of 2 to 3 weeks of treatment. For prophylaxis, you start at the time of engraftment and you continue till 100 days after the transplant. So just to summarize this in the form of a flowchart, so CMV viremia, you start induction so you did, based on your threshold that you have decided, you start induction with the ganciclovir or valganciclovir, and you monitor weekly. And after 2 weeks of therapy, the CMV PCR, if it is undetectable, and if the patient has disease, if there is clinical improvement, you stop the therapy at CMV PCR. But if the CMV PCR is declining, but it is still detectable, you continue the treatment until the CMV PCR is undetectable. And once the CMV PCR is undetectable, you switch back to preemptive monitoring until day 100 or 12 to 24 weeks after resolution of viremia, whichever is longer. However, in cases in whom after 2 weeks there is an increase in the viral load from the baseline, or there is a static viral load, and there is, in addition to this, if this is the CMV disease positive and there is no clinical improvement, you send for genotype resistance testing and you meanwhile switch the antiviral. So if the patient was on ganciclovir, you switch to foscarnet, and if the patient is on foscarnet, you consider switching to ganciclovir or cidofovir, and you adjust the therapy according to the results of the genotype. All right, so just this last bit, and I'm just going to go over to the the emerging therapies. So we know there are lots of names. Most of the vaccines and the newer antivirals are under investigation. One of the upcoming drugs to look out for is letermovir, and it is changing the future scene of the CMV infection, and it may be more utilized for prophylaxis. And the key takeaways are that the BMT patients are at high risk for CMV reactivation. It is very common. It significantly impacts the outcomes. Routine monitoring is essential. Early detection through PCR-based testing. It allows timely intervention to prevent disease progression. Management strategies, we talked about preemptive and prophylactic therapies. We talked about its impact on outcomes. And the challenges are with regards to the development of drug resistance and toxicities. And there are newer therapies which are in the pipeline. Thank you.
Thank you, Dr. Nasheen, for this excellent talk. So our last talk is by Dr. Ijaz Ahmed. He is consultant infectious disease at Shifa National Hospital. He is professor and chief of pediatrics at Shifa National Hospital. He is antiviral stewardship committee chair and also the hospital infection control committee chair.
Thank you. Bismillah ar-Rahman ar-Rahim. I really am thankful to the organizers from Shaukat Khanum Cancer Hospital, of the symposium, and also the ID team at Shaukat Khanum for giving me this opportunity to talk about an important topic. So I'm going to talk about stewardship in oncology patients, how to ensure optimal use of antibiotics in cancer patients. So we'll talk something about risk factors, etiology, outcome, how high infection risks are there in cancer patients, what the role of antibiotics in oncology, prophylactic, empirical, and targeted use of antibiotics, antifungals, and antivirals. Specifically, some of the topics that we will discussing are febrile neutropenia and antifungal therapy, and also overall general stewardship principles that would apply to oncology patients. So I think Dr. Mar and also Dr. Nasheen talked about the time periods after, for example, stem cell transplant, in which the patients are at risk. So we have a phase in which a lot of infections can occur, and specifically they differ by the timeline post-transplant. So this applies also to other oncology malignancy patients as well. So you will see that early on bacterial infections, and then some of the viral infections, herpes, and then CMV comes later, and other infections can occur, including fungal infections. So another timeline talking about the different immune system defects that predisposes one to these infections. So a lot of these are considered opportunistic infections as well. So there are also resistant concerns, multi-drug resistant or infections in transplant patients. And these are some of the risk factors. So unfortunately, cancer patients are exposed to a lot of antibiotics. So prior antibiotic use, the history of prior MDROs, recent or prolonged duration of hospital stay, and immunosuppressive disease, which can occur in cancer patients, are some of the risk factors which predispose to MDROs. So also the risk of colonization and subsequent infections of MDROs like carbapenem resistance. So immunosuppression per se alone also predisposes to these infections as well. So these include hematologic malignancies, neutropenia, bone marrow and solid organ transplants. So what is the impact of resistant organisms? So one, of course, is delay in appropriate therapy, increased mortality up to almost 50%, increased length of stay, and of course, huge costs that are involved. So, but what are the benefits of antibiotics? Because antibiotics saves lives, especially cancer patients. So they are essential for preventing and treating infections. Of course, you balance with AMR and a disruption of microbiome. And some of the risks, particularly to oncology patients, are fluoroquinolone resistant, streptococci, VRE, and other gram-negative fungal resistance, and even viral resistance. So if you delay treatment in cancer patients, there is increased mortality. There is also link between microbiome and cancer. So if you are exposed to antibiotics, it decreases the diversity of the microbiome. And of course, this leads to increased infections, high risk of GI graft versus host disease, and poor response to immune checkpoint inhibitors. So we know that antibiotic can save life, but especially in cancer therapies. But they are, of course, you have to balance. So what are the adverse effects of antimicrobials? There are, of course, systemic toxicity, drug-drug interactions are very important. And then MDROs, as we talked about. This increased infection risk, of course, can disrupt intestinal microbiome and also increase risk of C. diff infections. And in hematologic malignancy, patients are 6.5 times higher risk of infection. And for transplant patients, it's up to 9 times higher. What are the consequences of microbiome? It has a significant long-term effects, especially for oncology patients. And this diversity, which is lowered, linked to increased infection and poor survival as well. So we talk about strategies to mitigate these risks, and this is what we talk about stewardship. So this is a nice diagram that I want to show you. So there is a harmony, but after exposure, the resistant bacteria take advantage, and your body is at risk for infection and spreading resistant bacteria as well. How different types of transplant, graft versus host sources affect infections. One is that BMT infection rate is very high, up to 47.9% in the first month post BMT. And then infection also allogenic peripheral blood transplant, 32% or so. Donor type and graft versus host disease also impacts are different. And these, there is a definite role for this. And there is a high risk for late fungal and viral infections, which we have talked about as well. Acute graft versus host disease, 20 to 80% increasing risk of opportunistic infections. So there are some some unique challenges in stewardship in oncology patients. Of course, we know that they are already immunocompromised, they have dysfunction, they are prone to infections, tumor type may be also different, and they have increased susceptibility to infections. Some of the cancers are linked to infections, EBV, hepatitis B, C, etc. And then, of course, neutropenia per se from acute leukemia also leads to a lot of these infections, and hypogammaglobulinemia as well. Impact of cancer therapies as well directly also leads to myelosuppression, neutropenia, and lymphopenia. And of course, the patient's characteristic like age, poor health, worsened chemotherapy-induced neutropenia. Radiation also lead to mucosal barrier disruption, like mucositis, sinusitis, etc. And modern therapies and also are linked to increased infection risks. Once they are in hospital, they are heightened risk of healthcare-associated infections. They have indwelling catheters. They predisposed to MDROs and opportunistic infections. And a lot of factors which are considered to be important, of course, the conditioning regimens, duration of hospitalization, donor type, etc. And of course, before engraftment and post engraftment, there are different organisms which are responsible for these infections. So early on, bacterial infections from GI and healthcare-associated infections, Candida. And later on, CMV, Aspergillus, pneumocystis as well. Key components of stewardship in oncology include multidisciplinary collaboration. So you have to have a good team to cater for these patients. You have to have guidelines. These are available as well. You can make your own guidelines. Education training is important because you have to have the need of the cancer patients are very different. And monitoring surveillance is important to track the antibiotic use and monitoring resistance pattern as well. And then prophylactic strategies, which we talk about as well, important to prevent these infections. So there are a lot of guidelines from SHIA, IDSA, PIDS as well about stewardship for all populations, but there are some also talking about oncology patients. So you want to have better clinical outcome, minimize adverse effect, and reduce unnecessary antibiotic use as well. There are a lot of benefits of stewardship in cancer patients because ASP in general population benefits extend to cancer patients as well. So antibiotic approval process, feedback, etc., had led to decreased use of antibiotic use in these patients, which has improved survival as well. They have better outcome and you reduce the cost as well. Most of the guidelines do not talk about ASB guidelines do not talk about oncology patients, but you have to have this, and this has been emphasized by IDS in Shia as well, as far back as 2016. But there is variability in implementation, and even in the best centers, for example, USA, one study quoted that 35% of centers actively tracked outcomes related to antibiotic use. So there is variability in also implementing these specific guidelines as well. How to implement? We have go to basics, which we can talk about CDC core elements. There are updated guidelines as well. There are successful strategies, which there are good stories as well. Talk about how these can be implemented in cancer patients as well. So you have to have a team, and the team resolves around different different people, including the patient, oncology providers, ID physician, pharmacy, nursing, infection control, quality, microbiology, etc. So there is a need for multidisciplinary implementation, and this collaborative approach works within a framework, reporting, quality, and safety as well. So the key elements, of course, are education and training, data monitoring and feedback, and quality improvement initiatives. And this will improve your patient care and safety. Guidelines have to be in place, and these guidelines are essential. This has to be evidence-based, and you have to have your own experience, your own data, including antibiogram, own outcome, and then expertise integration. This includes your regular ASP team, but also oncology, hematology oncology is important, crucial for this to work. And then we talked about education as well. There are some examples in which it has been shown that improved survival rates noted in both adult pediatric patients with neutropenia following implementation of local fever and neutropenia protocols. And there is a high response rate in invasive aspergillus cases have been observed when first-line antifungal treatments are prescribed. These guidelines have to be flexible as well, because patient characteristics are different. Each patient may be different, and you have to adjust. And this is where the team comes in, where your expertise comes in. We have these guidelines in our institution as well. We talk about de-escalation, and febrile neutropenia, for example, is a very good way of antibiotic stewardship. And a lot of guidelines talk about de-escalating antibiotics, fluoroquinolones, prophylaxis in patients with febrile neutropenia who stabilized and who have defervesced, and has not led to any adverse outcome as well. Alternative is, of course, if you have a stable patient, cultures are negative, you can even stop the antibiotics. And this was a study in Spain which talked about a short course. And what they found was this study that supports the safety of shorter course antimicrobial therapy or prolonged therapy. And they had better outcome and also less antimicrobial toxicity. What does IDSA say? This is what the recommendation is, that should ASP develop facility-specific clinical guideline for management of fever and neutropenia in hematology, and they suggest that clinical facility-specific guidelines should be there for these patients. We have this in our hospital, treatment of fever neutropenia. So you start with empirical therapy. You have assessment. You have initial empirical therapy. You assess at 72 hours, and then you consider changing or escalating or de-escalating your therapy. So you have different scenarios, what to do in that. And this, you also try to monitor your consumption. So we specifically look at different departments in even oncology. We looked at DDDs of all the antimicrobial use. So antifungal stewardship, again, another important component which is often missed in the general ASP principles, but this is important because invasive fungal infections, as we talked in early this morning, is important as well. Uh, for this, you have to have antifungal prophylaxis in place. You have to make sure that you have rapid diagnostics. Fortunately, in some of the centers, we have biomarkers available, and we can use that galactomannan and beta D glucan as well. So you have more targeted therapies. It will reduce the reduction of empirical therapy and timely discontinuation as well. These stewardship principles improve patient care, minimize antifungal use as well. And so it's important to broaden your ASP and includes antifungal stewardship as well. So this is another IDSA recommendation for stewardship principles, and they suggest that to improve appropriate prescribing of antifungal therapy in patients, you should have a ASP fungal prophylaxis and targeted therapy as well. The study from Lima, Peru, from lower middle income countries also highlighted the successful implementation of AMS in such countries with high reduction of antibiotic use, high acceptance, and high adequacy of surgical prophylaxis. So just briefly, we have surgical prophylaxis. This for our BMT. This you have antimicrobial prophylaxis, and it has been shown that there is effectiveness for some of the antibiotics, such as quinolones, can reduce gram-negative infections in neutropenic patients. NCSS and guidelines also recommend fluoroquinolone prophylaxis, which for neutropenia lasting more than 10 days. And then, of course, every treatment has their side effects. So C. diff has to be kept in mind. Resistance has to be kept in mind. And then, of course, if you have a patient on prophylaxis, they get a fever, then you have to escalate your therapy to anti-pseudomonal drugs such as piperacillin, tazobactam, or meropenem. Local resistance pattern plays a great role. So you review your local resistance pattern. Septron is another prophylactic agent which is available, which has a good benefit, but it has also adverse effects. So you have to weigh the risk and benefits as well. Antifungal, we talked about, again, preemptive and empirical therapy. There is a definite support for this preemptive therapy from Cochrane review, and then for fever neutropenia with use as well. We have this amphotericin use guidelines in our hospital as well. Antiviral use and prophylaxis stem cell transplant patients. Dr. Noshin talked about CMV already, that there are new guidelines available, which newer agents available, what to do in Ganciclovir resistant cases. So I'll skip this. And then, of course, you have to monitor your patients for different parameters when you're doing ASP. So one, of course, is adverse events. For example, when we started caspofungin, we came across some ADRs, and we also reported that we looked at some of the reasons and how to manage these ADRs. Voriconazole, again, linked to increased LFTs in our oncology patients. And the reason was because there are a lot of these treatment that are being given to cancer patients. They have drug interactions, and you have to adjust, and you have to specifically not use voriconazole. You can use fluconazole instead. So there's different mechanism you can go about. We do a compliance. So we looked at compliance of, and this is you can't see, but the compliance rate of different restricted antibiotics has to be also looked at in your setup. Then we'll talk about expansion of diagnostic accessibility testing of methods. So if you have good testing for infections, then you can also use that for your stewardship principles. These include rapid molecular testing, genotypic, phenotypic testing, and some of these are available in some centers as well. This is a CDC summary of ASP interventions specific to oncology and hematopoietic stem cells transplant patients, and these core elements and what intervention specifically you have to do. So these include from leadership to pharmacy to tracking, reporting, and education. So you have to have guidelines, which you talked about: fever, neutropenia, antifungal prophylaxis, CMV, and dose adjustment, and what to do in cases of MDROs. There are some unmet needs. Most important is fever, neutropenia. Usually, these patients do not have a specific diagnosis. What to do about this? So this is what needs to be looked at, and what to do about resistance. Some of the resistance, especially in Pakistan, you are now getting SDROs, and you have to have some strategy to cater for that. Then shorter duration of therapy has to be looked at, and I think we need to have this in our setup and look our data, but whether longer or shorter duration makes any difference in our population. Guideline development and targeted antimicrobial therapy is also is one of the opportunities for improvement. So in short, ASP is important. Antimicrobials are important for treating infections. Resistance is a big issue. Then antimicrobial use, the gut microbiome disruption has to be kept in mind. The impact of therapies, including antimicrobial, is also important. And for ASP, you have to have collaborative, you have to have a team, and you need more research, local research, especially how to use optimal therapy, and look at your resistance, your local hospital data for ASP guidelines as well, making ASP guidelines. So overall, the idea is ASP is to ensure that you preserve antimicrobial effectiveness to improve patient care outcomes. Thank you.
Thank you, Dr. Jas. So now we can take questions. Any questions from the audience? Nadia, please come over to the mic.
My question will be from Dr. Ahmed. Dr. Ahmed, you have presented the data from Indus. So the use of the amphotericin was among all the 10 patients. I think, okay. So my question is that, Dr. Ahmed, from your data, have you used liposomal amphotericin B in all the patients, or you have used the standard one? Thank you.
That's a great question. So majority of our use has been for ampho-deoxycholate. मैं यहाँ से सवाल का जवाब दूँ? Yeah. अच्छा, okay, thank you. Majority of our patients, we've relied on ampho-deoxycholate, especially because I was looking at the older data, so like pre-2017, and we were, for cost reasons, relying on that. Now we have more access to liposomal, but again, वो black channel से आती है, कैसे आती है, उसके अपने issues हैं actually availability के. But previously we wouldn't have any liposomal available, so I'm not sure how. But even now, though, due to cost, primarily we rely on deoxycholate.
Any other question? Dr. Amir, I just had a question. For patients who have AKI or who develops AKI while on amphotericin, do you really need to adjust amphotericin dose? And what dose would you recommend for Mucor especially, because you need to have higher dose, and what is the maximum that you can give?
So it's definitely a challenge because we want to get good disease control. And in the process with deoxycholate, we will run into toxicity issues along the way. We try to manage with fluids, kind of preemptively try to hydrate them as much as we can. Usually, our patients presenting to Indus present very late, so they have a lot of disease burden, and therefore we rely on higher dose typically, and they require multiple debridement. So in nowadays, if we run into AKI with deoxycholate, we will switch them to liposomal ampho. Some of those patients, maybe half of those, will do better and tolerate that better, and some won't, and then we get stuck. In the past, due to resource limitations, they would do like interrupted therapy. So that means you have to admit the patient for a much longer time, then go off the AMPO for 2 days, let the creatinine come down, hydrate them some more, then restart it. So in the past, it would be a much bigger challenge. Now we have access to isavuconazole for specifically for this nephrotoxicity concern. The issue is getting approval from the administration to pay 3 lakhs for a month of isavuconazole. But technically, the answer is isavuconazole specifically for nephrotoxicity.
The reason I'm asking because my experience is that usually when I go for a consult, they stop, and I will tell them that no, please continue. Same dose, and believe me, their creatinine actually improves because there are some other, probably the infection itself, probably the sub, and tell them to look at some of the other nephrotoxic drugs, which can be removed or decreased, and your ampho can be continued even with the dose because even Stanford says that you do not need to adjust even hepatic or renal adjustment, unless, of course, you have a direct evidence that this is the cause. Uh, Am I correct or not? And what is the
Absolutely.
maximum dose that you would give
Absolutely. So we have the
for
same
Mucor?
approach. For Mucor, the recommended dosing for deoxycholate is 1 to 1.5 mg per kg. Our patient population is usually a very thin, lean, malnourished population. So we'll start them off at 1 mg per kg. And we also do exactly as you've recommended. So we avoid stopping therapy. We switch in case they are not tolerating even 1 mg per kg of deoxycholate, we'll switch them to liposomal. We don't dose reduce more than 1 mg per kg.
So I think the maximum that I can give is 75 milligram day, correct?
Uh,
It's
it
1.5 if you're giving.
Right.
It-
It depends. So we can give higher for Mucor. We can give higher. Of course, it's weight-based dosing, and appropriately dosing it by weight is important. But usually our patients are average less than 75 kgs most of the time, so we don't run into that.
Amir, question, comment. So you mentioned about one of your patients whom you gave amphotericin thrice weekly. How did that work? Because we know we can't keep the patients admitted, and then there is a risk of renal toxicity, and the patients who live for like far off areas, they have difficulty in monitoring. How did that work?
So we've before I joined at Indus, actually Dr. Naseem Salahuddin had been doing this for a very long time because a lot of the patients she would be seeing at Indus would all of them would be coming from far away. So by and large, she would try to admit the patients maybe for a month or so until their disease is controlled or maybe lesser. And then when they had to go back, we have a separate infusion center, which is like our daycare infusion center. So patients will come in, get their infusion and go home. And that way they would come Monday, Wednesday, Friday, and they would continue like that, of course.
Right. And then you mentioned about that data, which shows 40% sensitivity for posaconazole. So that is very alarming. Any comments
Yes.
on that?
Yes, that's Dr. Kauser Jabin's data, and she was kind enough to share. But I was actually quite alarmed by that as well because that means that we really can't rely on posaconazole very much. And even for isavuconazole, it's hardly just been launched in Pakistan, and she's finding this data from last year, so it's quite alarming. I think for Mucor, that's why the global guideline wants us to use AMPHO because the sensitivity data is overall better. And then I think we'll have to invest in ICView where we can't keep patients for long enough or run into toxicities.
And lastly, I'm very thankful you shared the evidence regarding the use of dual antibiotic. There's no evidence and no benefit of using because many times we get consults from our colleagues about adding another antifungal, which obviously is not indicated.
Absolutely. I specifically wanted to comment on combination. Like you said, there's nothing to support its use, and then toxicity concerns and whatnot. Only like in salvage therapy where they're completely failing, etc., etc. But even for those cases, it's important to do debridement where possible.
Yeah, I was just going to say that for mucor, or even for any invasive fungal infection, sometimes you have to do multiple debridements, and that is maybe save the patients actually. And COVID had given us the opportunity to study some of these patients, even immunocompetent, healthy young had invasive fungal infection, and they were saved because their immune system was intact, and they were saved. But with the risk, with the cost of prolonged hospital stay, some disfigurement, and also the morbidity and the agony of being in and out of hospital.
Absolutely. Even at our center's data, patients that underwent repeat debridements were the ones who eventually did better. And we often have to, lack of a better word, pester our surgical services, but that's in the best interest of the patient. Thank you.
So, Dr. Yaz, I have a question for you. Because you work as an center and you have an institute at your back. So we look forward from the data which is coming from the institute rather than from individual persons. For example, doing an antibiotic stewardship in a higher risk population and even the antibiotic stewardship in the non-risk population in Pakistan is very difficult. So if you are practicing it at Shafa, and is there any data which we are publishing in immunocompromised patients, and how challenging it is to involve the oncologist as well, because sometimes the specialty is not willing to de-escalate the therapy and coming to the shorter duration of therapy instead of they just insist to continue and complete the duration, specifically in pediatric population. So I think we should all come up with the data and an institute becoming the lead, and the people all across the country should be contributing, and we should make our own publication. This is just a comment as well. And
Yeah, I think it's a good
Thank you.
suggestion. We do have data. We have not published it. Yes, these are some of the challenges, stewardship in cancer patients. How do you convince the oncologist, hematologist? And believe me, that is not easy. You have to have full, make sure that you uh, get them or deal with them directly. So what we have done is that we have clinical pharmacists who work with them during their rounds. One is that we work with them on making guidelines, and then they take their input because they can own it, especially like BMT is a high risk population. These include both adults and pediatric patients. And we are doing a lot of bone marrow transplants for newer indications, including pediatrics. So we will see these issues, and I'm sure that we will have some data to share down the line. Right now, we have very limited data, or but the strategy is to work with them to be to ensure that you engage with them all the time, and I think then they will listen. For example, I can give you like we found out like azithromycin, one of the highest users were employee health, dermatology, pulmonology, and oncology. So oncology, we had to go and we talked to them, and we knew which one are we doing it. So we talked, we had that data. We went and talked to them, and some of the had immediate impact. But oncology, of course, is difficult because they have to have some prophylaxis given to these patients. So I think working as a team and in making sure that you uh, you show them data, you have provide them alternatives, like we all do that all the time. Like linezolid was being used by a lot of our colleagues, and then we have better alternatives than linezolid. So we had to convince our dermatologists, our surgeons, and neurosurgeons who were using this, and now linezolid cannot be given without our approval. So I think this can work for oncology patients as well. So I think you have given us a good suggestion, and we'll work on that. Yeah, thank you.
Yeah, because we look forward the institute, because we also want to contribute, and the data which has been presented by Dr. Amir, and also in the public sector hospital of Pakistan, we are using the M4D oxycolate, because we have we don't have liposomal amphotericin. So if we publish that data together from all across Pakistan, or make some kind of groups specifically for the high risk patients, so I think we can just contribute a lot in the management guidelines, and there should be an equal and implementation all across Pakistan. So this is something that we should all take from this meeting.
Yeah.
Thank you.
Dr. Jaz had a question for you. For the guidelines talk about using POSA for neutropenic and GVHD prophylaxis, antifungal prophylaxis. At Shaukat Khanum, how is that approached, and is it even available easily? Yes, how is antifungal prophylaxis? Like, which azole do you rely on for
Okay,
antifungal?
okay. So these posaconazole, and these are not available, unfortunately. So you have to have a range for it, especially in patients who are not responding. So a lot of patients on their own, they will arrange for it. But sometimes we have through pharmacy and through DRAP, we have arranged some of these uh, agents, including antibiotics, antifungals as well. Uh, Usually we have uh, sometimes the patients bring a lot of these in bulk, and they are unused, and they would actually donate it to the hospital pharmacy, and we have used that, including liposomal amphotericin uh, as well. So liposomal is also not available, uh, and it's very expensive, and but we have used in multiple patients from one single source, that sometimes some people arranged it. So through DRAP, through pharmacy, their channel that was used. The patients itself, for them, it's very difficult to arrange on their own, but sometimes it has happened. They can get these easily through, like, Afghanistan and India, for example. So they have arranged. We had contact even in India a long time ago. We used to have posaconazole from there, and it was available. Not right now. So there are different ways of doing it, and I think we need to have a better way, a better supply chain than this, actually. No, there should be one question for Noshin before we end.
I can ask one last question. Dr. Nashin, if you can comment on the role of mirabegron in CMV infection.
So Maribavir is still an investigational drug. There are some trials ongoing where it has been found to have some benefit in patients in whom there is refractory disease. But there is still a lot of concern surrounding its efficacy, and it is being used as, it will be used as somewhat of a salvage treatment down the line. So it cannot replace the role of ganciclovir, valganciclovir at this point in time, but it is being studied as a drug for refractory cases.
Yeah, very limited. Thank you. I think we are at the end. I would like to again thank Shaukat Khanum for making sure that ID is represented here in this important symposium. ID will always be part of cancer therapy patients. And I think we have a very good ID teams in every institution, and it is growing in stature as well as in numbers, and also um, they are more emphatic, they are convincing, they have more data to present. I think this will go a long way in better outcomes for our patients. Today we talked about important aspects of some of the infections in cancer patients. Mucor, I think, very important. Other fungal infections are similar. CMV, again, is a big challenge for our patients, especially bone marrow transplant patients. And I think stewardship is the way to go in making sure that our patients get the right therapy the right treatment and ensure that they have lower cost, lower side effects, and better outcome actually. So we learn from each other. I think we have learned a lot today, and everyone should go back and apply some of these principles that we learned today. Thank you very much.